Good morning. The hearing will come to order. I want to thank our witnesses for being here today. We look forward to your testimony. Today we meet to examine the changing landscape of small and solo physician practices. For many years, newly licensed physicians typically joined a private practice or opened one of their own. According to Merritt Hawkins, a national physicians recruiting firm whose president is testifying today, only 1% of its searches in 2011 were for independent practices, the lowest in the firm's 28-year history, and down from 22% in 2004. Many people believe that if small and solo practices are to survive, they will look very different than the medical practices in past years. These shifts appear to be rooted in increasing economic pressures. Younger physicians may want freedom from the long hours and administrative burdens of owning a private practice, and they need financial help with student loans, medical liability insurance, and health information technology. Established physicians have cited declining reimbursements and increasing regulations, such as the reporting requirements for health information technology and the push towards accountable care organizations, as reasons small and solo practices have become economically unsustainable. In a recent Wall Street Journal op-ed, Daniel Henninger described the practice of medicine as the healthcare law's biggest loser. We are interested in learning how all of these factors, including the requirements of the healthcare law, which was upheld by the United States Supreme Court, may affect small practices. We have an exceptional panel of witnesses to help us understand these issues. Welcome. We look forward to your testimony. Well, Mr. Schrader, Dr. Schrader, of veterinary practice, do you have any opening statements?
I'll just submit mine for the record, Mr. Chairman. Thank you.
Thank you. If subcommittee members have an opening statement prepared, okay, ask them to submit for the record. I'd like to take a moment to explain the timing lights to you. You will each have 5 minutes to deliver your testimony. The light will start out as green. When you have 1 minute remaining, the light will turn yellow. Finally, it will turn red at the end of your 5 minutes. I ask that you try to adhere to the time limit. Our first witness today is Mark Smith, president of Merritt Hawkins in Irving, Texas, a leading physicians recruiting firm for small independent practices, group practices, and hospitals. Mr. Smith has over 21 years of experience with Merritt Hawkins and is an expert in medical staff planning and physician staffing. He is a graduate of Oregon State University. Welcome. You have 5 minutes to present your testimony.
Thank you. Mr. Chairman and distinguished subcommittee members, good morning. My name is Mark Smith, and I'm president of Merritt Hawkins Associates, the largest physician search and consulting firm in the nation, and a member of the AMN Healthcare. In the course of my 24 years of Merritt Hawkins, I've consulted with thousands of physician practices, and my company has produced numerous white papers, surveys, and books concerning physician practice patterns and related topics. I appreciate the opportunity today to address the subcommittee on the decline of solo and small physician practices. For those who remember the Marcus Welby MD TV show, may still have an image in the mind of a physician as a small business owner running their own practice. This classic model of independent physician practice still exists today, but is rapidly becoming a relic of a bygone era. Today, physicians are more likely to be employees than they are to be medical practice owners. This is particularly true of medical residents completing their training. In the 2011 survey, as mentioned by Merritt Hawkins, only 1% chose to be a solo private practice physician. By contrast, 60% said they would prefer to be either a hospital employee or work for another entity. In short, virtually no one wants to be Marcus Welby anymore. This represents a fundamental transformation in the structure of physician practices away from the classic private practice model and towards employment and an increasing number of other practice options. There are 5 primary reasons for this transformation taking place, and they include flat or declining reimbursement, growing regulatory and administrative burden, malpractice cost, information technology implementation, and the effects of health reform, both legislative and evolutionary. First, reimbursement. In the days of Marcus Welby, both Medicare and private insurers typically paid physicians for usual and customary charges. Physicians generally were paid for services invoiced at an amount above their cost of doing business. The system has been repeatedly modified in an effort to reduce costs and to manage care. Physician reimbursement in some cases has been cut or has not kept pace with inflation. As a result, today, physicians see little connection between their costs and the amount to which they're reimbursed. This is a difficult business model to sustain. Some small private practices are having trouble keeping their doors open. There have even been reports in recent months of a growing number of practices going out of business, something I've not seen in my 24 years with this organization. By contrast, employment provides physicians a safe harbor from today's challenges and from the uncertainties that lie ahead. Regulatory burdens, virtually all businesses are subject to regulatory compliance of some kind, and medical practices are no different. As a small business owner, physicians must abide by equal opportunity and worker safety laws, state and local ordinances, and many other rules and regulations. Adding a layer of complexity, physicians work in the most highly of all regulated professions, having to comply with HIPAA, Stark laws, Medicare, and many other regulations. It's concerning to me that a survey conducted by Merritt Hawkins stated that physicians spend 26% of their time doing paperwork. Many physicians see employment as a way to escape the rising tide of risk and regulation and allow them to focus on patient care. Malpractice. Among the various costs of doing business, small business owners must pay for their own malpractice insurance, the cost of which could be debilitating. For example, the annual premium for malpractice in some parts of Florida for an obstetrician can exceed $160,000 a year. As malpractice rates remain high, employment becomes an attractive option to physicians, as employers typically pay for this benefit. For a variety of reasons, physicians are obliged to incorporate a growing level of information technology into their practice, particularly EMR or electronic medical records. While the federal government has provided reimbursement funds for physicians to implement EMR, many still find it difficult due to a lack of time and available expertise. EMR implementation is a key example of how the resources, expertise, and time of a small medical practice owner are being taxed in today's increasingly complex medical environment. A growing number of physicians are embracing employment again as a potential refuge from these challenging concerns. Health reform is a driver of a number of healthcare trends, including the decline of small private practices. Health reform encourages the consolidation of physicians into larger entities to gain economies of scale. In addition, health reform promotes the formation of new delivery models, such as accountable care organizations, or ACO, which depend upon hospital and physician alignment in the use of advanced information technology. ACOs are also risk-bearing entities and as such require a high level of administrative and business expertise. It is difficult for a solo or small practice physician to participate in these models, which naturally lend themselves to larger organizations. Combined, these factors and others have created conditions in which small private practice is increasingly untenable. This model is more likely to survive on either small rural areas where there are few physicians, and even in these settings, physicians will need to affiliate with larger entities. Otherwise, physicians are likely to be employed by multi-physician groups or by hospitals, and the era of Marcus Welby will rapidly disappear into our rearview mirror. Thank you for the opportunity to address the subcommittee and for examining the challenges facing America's solo and small practice physician.
Thank you for your testimony. At this time, our next witness is Louis F. McIntyre, medical doctor, a board-certified orthopedic surgeon practicing in White Plains, New York. Dr. McIntyre and his partners had operated a small practice since 1994, but in the fall of 2011, they sold their partnership to a hospital group and joined the hospital as employees. He earned his medical degree from the New York Medical College at Valhalla. How do you say that?
Valhalla.
Valhalla.
Land of the gods.
Okay. Dr. McIntyre is a member of the American Association of Orthopedic Surgeons and is testifying today on their behalf. Welcome. You have 5 minutes to present your testimony.
Thank you, Mr. Chairman and members of the committee, to allow me to testify today, tell my little small practice story. I joined Westchester Orthopedics in 1994. The practice resided in a small office and we had a few employees. We wanted to grow the practice and improve the quality of care that we delivered, so in 1995 we moved to a much larger office space, hired more physicians, free parking, patients love free parking, and added more docs. The late 1990s brought two challenging trends: decreasing reimbursement and increasing business costs. We needed more employees to handle the clerical demands of managed care, and yearly malpractice premiums went from $40,000 to $110,000 per doctor. As a small practice, we were unable to negotiate favorable rates because we didn't have market share. And we formed a network of orthopedic surgeons to try to change that, but we were unable to affect rates because of antitrust concerns. To remain viable, we added more doctors and ancillary services and implemented an electronic medical record. Our total cost for the EMR implementation was about $500,000, which represents about $100,000 per doctor. Initially, we saved some money with the EMR, but over time that was negated by the need to upgrade the system and hire data entry personnel. We built an ambulatory surgery center and acquired additional office space to build a physical therapy center to standardize the quality of the physical therapy that our patients received. When completely configured, we had just under 50 employees. All had health insurance, all had a generous profit-sharing plan, all had paid vacation and leave and sick leave. Patients appreciated the convenience of being able to receive all their musculoskeletal care in one coordinated and contiguous setting. The negative pressure on reimbursement, however, continued. The American Academy of Orthopedic Surgeons estimates that orthopedic surgeons' Medicare reimbursement revenue decreased 28% in the last decade. Reimbursement from private payers has also fallen, and practice costs, unfortunately, continue to rise. Laws recently passed by Congress have further stressed private practice. The American Recovery and Reinvestment Act mandated the adoption of EMR for all physicians serving Medicare patients. Even though we had previously implemented an EMR, the meaningful use criteria accompanying the regulations still represented a significant cost burden for us in terms of data collection and quality reporting rules. The Patient Protection and Affordable Care Act proposes new, complex risk-sharing reimbursement methodologies that many small practices, if not most, won't be able to comply with. The combination of decreased reimbursement, increased reporting requirements, huge outlays for technological improvements, and uncertainty about future potential earnings are driving physicians to seek employed positions. Doctors know that they cannot meet all the demands placed upon them now and see patients at the same time. According to the AOS, the employment of orthopedic surgeons by hospitals has increased 300% in the last 5 years. Last year, we decided to become hospital employees. This year, the other orthopedic group in our town also is going to become employees of the same hospital. The multi-specialty group next to us, WestMed, has 225 employed physicians. Clearly, the employed model is winning in Westchester County. There are advantages for employed physicians. Doctors have more financial security with a salary. They no longer worry about losing money taking care of uninsured patients. They are freed from dealing with some of the troublesome human resource and IT issues. But employment, however, significantly decreases physicians' autonomy in affecting the care environment. Physicians are in a unique position to interact with patients on a daily basis and identify deficiencies in care. Physicians' ability to advocate for patients is diminished by employment because they no longer manage the care environment. As more physicians seek employed positions, there will be a generation of physicians who will have never experienced private practice and the business of taking care of medicine. They will be unaware of the costs and management issues of providing care. There is concern that employed physicians will see less of a need to join medical specialty societies that have added great value to patient care. How these concerns will affect the profession is unknown at this time. In the future, I fear that physicians may unionize to protect their economic interests. I believe this would herald the end of medicine as a profession and the start of medicine as a trade association. It is rarely mentioned, but private practice employs people and pays taxes. A recent study conducted by the Medical Society for the State of New York showed that the private practice of medicine was the 5th largest employer in Westchester County, 2nd in business establishments, 3rd in personal income taxes paid, and 7th in corporate sales taxes paid. As a hospital employee, our practice is now tax exempt. The loss of employment and tax revenue resulting from private practice physicians migrating to hospital employment may be significant and worthy of further study. Finally, there will not be employed positions for all the doctors of Westchester County or the United States. There is and will continue to be an increased need for physicians, especially with the implementation of PPAC in 2014. If private practice disappears, patient access to care, local employment, and tax revenue will suffer. We need to strengthen private practice as well as other models of healthcare delivery to ensure patient access to quality care. Thank you for the opportunity to share these thoughts today.
Thank you, Dr. McIntyre. Our next witness is is Joseph Yasso. Junior DO, it's Doctor of
Osteopathic medicine.
Osteopathic medicine, I'm sorry. A board-certified family physician, medical physician, and medical director of the Heritage Physicians Group in Independence, Missouri. He is a member of the American Osteopathic Association and is testifying today on their behalf. Welcome. You have 5 minutes to present your testimony.
Thank you. Chairman Kaufman, Ranking Member Schrader, and members of the subcommittee, on behalf of the American Osteopathic Association, thank you for the opportunity to testify today. As a board-certified osteopathic family physician, I have proudly treated patients for over 30 years. My current practice is comprised of 3 physicians, including myself and a family nurse practitioner. We are owned by the Hospital Corporation of America. Today, I'm pleased to share with you my personal experience of how impactful healthcare realignment and regulations are upon decisions made by new and established physicians alike. After leaving the Army in 1980, I entered a small practice with 2 other physicians that we ultimately chose to sell in 1992 due to multiple financial and regulatory concerns similar to those my colleagues in practice are facing today. Today, physician practices face new demands as required by statute and regulation. These include the adoption of electronic health records and electronic prescribing systems, preparation for coding under ICD-10, implementation of quality measures, and adjusting to other changes in the healthcare delivery system. These additional policies and procedures are important and are primarily beneficial to efficiency as well as to providing improved patient care. However, each new requirement can be quite costly to the physician practice operating as a small business. The burden on small practices is particularly disproportionate, detracting from the time available for patient care. In addition, the looming physician payment cuts under the SGR force small practices with limited revenues and narrow margins to make difficult decisions about whether to lay off staff, reduce the Medicare patient population, defer investments, opt for early retirement, or sell their practice. My first small practice of 3 buckled to these concerns, and we opted to sell. Today's medical school graduates are faced with difficult decisions after completing their education and training. The average osteopathic medical school graduate has a debt nearing $200,000. As you can imagine, this makes the prospect of opening a small practice extremely daunting. This spring, the American College of Osteopathic Family Physicians conducted a survey of its membership, including questions related to practice types and settings. The survey found that 60% of family physicians are employees with no ownership stake in a practice. Often the overwhelming collective burdens I have mentioned today are cost prohibitive and outweigh a physician's desire to enter or remain in a small or solo practice. There are also physicians who wholeheartedly embrace the choice of becoming an employed physician. Physicians should not be forced to enter an employed situation out of pure necessity. They should retain their option to choose their ideal practice type, absent undue financial considerations and regulatory burdens. Medical homes and ACOs provide opportunities for physicians to continue managing patient care while still being able to operate as a small or solo practitioner. Neither model requires a physician to be employed by a hospital or large health system in order to be successful. Appropriately aligned, incentives can serve to foster success regardless of practice type. Regulators should be cautious in creating additional financial burdens on physicians that would inhibit their ability to choose the practice setting that is most appropriate. In closing, the transformation of the practice of medicine has undoubtedly impacted the ability of physicians to thrive in a small practice or as solo practitioners. However, physicians are adapting to the changing practice of medicine by becoming patient-centered medical homes and participating in shared savings programs. As we work to improve the healthcare delivery system for patients, physicians must be provided appropriate payment and incentives to practice effectively in the setting of their choice. Patients deserve this level of access. I would again like to thank you and the members of the committee for affording me the opportunity to share my experiences and the AOA's perspective regarding this important topic affecting osteopathic physicians and our patients. We appreciate the work that you do to promote policies that enable physicians to successfully operate as small businesses absent undue regulatory and financial burdens. We look forward to working with you in the weeks ahead and months ahead to ensure that congressional action fosters rather than impedes the physician-patient relationship.
Chair now yields to Dr. Schrader for the introduction of our next guest.
Thank you, Mr. Chairman. It's my pleasure to introduce Dr. Jerry Kennett. Dr. Kennett has practiced interventional cardiology in Missouri for the last 30 years as a senior partner of Missouri Cardiovascular Specialists and vice president, VICE president, and chief medical officer at Boone Hospital Center. He's maintained a busy clinical schedule while also participating in a lot of clinical research and education. He's testifying today on behalf of the American Academy of Cardiology. The college has 40,000 members and is dedicated to enhancing people's lives through cardiovascular treatment and intervention. We welcome Dr. Kennett.
Good morning. Thank you, Ranking Member Schrader and Chairman Kaufman, and members of the subcommittee. We appreciate your inviting us to testify here today. I am Jerry Kennett, Chairman of the American College of Cardiology Advocacy Steering Committee. The ACC, as said, is a 40,000-member medical society serving the needs of both providers and patients. I'm a cardiologist with Missouri Cardiovascular Specialists, a 17-person cardiology and cardiovascular surgery practice in Columbia, Missouri. My group was one of those typical office-based practices with over 100 employees. Our practice included a cardiac diagnostic center where patients had easy access to echocardiograms, stress tests, and even an outpatient cardiac catheterization laboratory. A little more than a year ago, our group was an independent practice, but now we are integrated with Boone Hospital Center in what is termed a professional services agreement. According to the 2011 Lewin Group report on the economic impact of office-based physician practices, these small businesses such as ours account for 4 million jobs across the United States, with $833 billion in wages and benefits. Physician practices are different from almost any other small businesses. The payment for services performed is not controlled by free market dynamics, but instead payment is tightly regulated by Medicare and Medicaid, and private payers who essentially follow the lead of the government with the recipient of the services are patient, often paying only a fraction of the cost. Recent events have had a dramatic effect on private practice cardiology. The ACC estimates that 60 to 70% of our current physician members have now integrated with hospitals. Why has this happened? There are a variety of factors that have contributed to this evolution. The prominent reasons relate to Medicare physician payment not keeping up with actual practice cost, direct cuts in Medicare physician reimbursement, and increased administrative and regulatory burdens. All these add up to tremendous uncertainty among physicians as to what the future holds, and so many physician practices such as mine see hospital integration as their only choice. Every year since 2002, physician practices have been threatened with significant cuts in Medicare reimbursement, the so-called SGR. This uncertainty stifles physician practices from making real investments aimed at improving coordination, reducing the current fragmentation of care, and reducing waste. Another major turning point for cardiology occurred in 2010 with the Medicare physician fee schedule, which reduced payments to cardiology practices for some in-office procedures as much as 35%. How many small businesses could survive a 35% cut in payment for the exact same service? Our practice, like many others, could not. There are also a significant number of regulatory and administrative burdens that contribute to the uncertainty for physician practices and hinder their ability to grow. A few examples are audits. While physicians' claims for services are generally subject to contractor medical review, greater scrutiny in recent years has increased cost and uncertainty. Physician claims must comply with multiple edits as well as recovery audit contractors. ICD-10. The Center for Medicare and Medicaid Services will soon implement ICD-10, a diagnostic coding system that will increase the number of diagnoses a physician has to choose from 15,000 to over 87,000. Multiple Medicare penalties. Starting in 2011, Medicare began to penalize physicians for not meeting the requirements of certain incentive programs. In the coming years, physicians will be penalized for not prescribing electronically, not participating in meaningful use of an electronic medical record, and not submitting quality data through the Physician Quality Reporting System, as well as a yet unidentified value-based modifier. Finally, physicians have significant anxiety regarding the future of Medicare payment reform, as you have heard. The new payment methodologies, such as ACOs, bundled payments, and medical homes, will require additional staffing with no assurance they will produce any shared savings. Physicians are afraid of being left out. In conclusion, the financial pressures associated with declining reimbursements and rising operational costs on private cardiology practices have resulted in the rapid migration of practices to hospital affiliation. Continued cuts in Medicare reimbursement, combined with increasing overhead costs, increased regulation, unfunded mandates, a micromanaged payment system, and an uncertain future are making it difficult for practices to remain viable. We believe that a well-functioning Medicare payment system could provide opportunities for physicians to practice both independently or as employees of a hospital. Increased payment should come from increased quality and demonstrate appropriate utilization, and physicians should be appropriately paid for the increasing expectations associated with the practice of medicine. Thank you for the opportunity to share my views and look forward to any questions.
Thank you so much for your testimony. I really appreciate all of you taking the time to be here. Let me just open it up with a few questions, and then I'll defer to my colleagues on the subcommittee. All of you had mentioned rising administrative cost as being a factor in hurting the small practices, solo and small practices. Are there, back home in my district, I was just talking to a woman who is starting a new concept to help child care providers by simply doing their administrative work, the back office work to allow them to focus on child care, and her entity then focuses on administrative compliance. Is there any movement to assist small practices with these third-party organizations? I know they've existed in, say, Medicaid, Medicare, but just in overall administrative work and all the compliance things that you have to do. Are there such entities emerging to relieve some of the cost pressures on small and solo practices?
There are businesses that have evolved to fill that need that exists with physicians having more and more of these administrative burdens placed on their shoulders, and some can work quite well. And the new legislation that intensifies fairly greatly the penalties, as mentioned, are very significant. But even if you are able to outsource that, it comes at a cost. And it comes at a cost when you're looking at your revenues either being flat at best or declining. So again, it opens up that option to make employment seem much more attractive as to transferring that burden to someone else. We mentioned in the survey that Mayor Hawkins had that 26% of a physician's time was in paperwork. And so in essence, you have a hidden army of about 200,000 physicians out there that are doing something other than they were trained. So anything that we can do to relieve that burden outside of just the pure employment option and allow them to focus on patients, which I'm sure that our three folks that are sitting at the table would much prefer to do than to do paperwork, would be a great assistance.
Dr. McIntyre.
My experience in our practice was that there were many entities that could help us with individual things. Billing, we could outsource billing. IT, we could outsource a lot of stuff to IT. But there wasn't any umbrella organization that would come in and say, we'll do it all for you. Sounds like a great business, actually. So the hospital subsumes all those tasks for you. And I think that's what makes it attractive to many physicians who are just looking for a way out so that they can concentrate on patient care instead of regulatory burdens.
When we sold our practice in 1992, of course, we didn't have the IT piece to worry about back in those days, but we were doing our own billing and managing the practice ourselves and doing quite well. When we sold to TriSource, they right away started charging us a $7,000 a month management fee and a $7,000 a month billing fee. That was $14,000 a month of overhead that we didn't have before. So all of a sudden, a practice that was in the black was now in the red because we had such a tight margin. And so, you know, if you do those kinds of things, that's the cost that you have to bear to get those things done.
You know, in private practice, you know, there's always consultants and companies that want to come in and do things for you, know, that says they can do it more efficient and better, and usually that doesn't turn out to be the case, that usually the costs are as great as before. As you might imagine, you know, in these small businesses, that physician practices, they're so regulated and so many things we have to deal with that your overhead sometimes in small practices can be as much as 80%. So it becomes overwhelming, and that's one of the reasons that, as mentioned, it drives physicians toward employment.
Okay. Most of you mentioned medical malpractice as an issue in the smaller solo practice dissolving and moving into as employees or into a larger physicians group or employees of a hospital. But those costs don't change. Is it that just as a function of cash flow, if you've got a small practice and there's a bump in cash flow and you've got this big overhead issue like paying your premiums on a medical malpractice policy, is that essentially the problem? Because I don't see where the costs are changing. They're very high, obviously higher than they ought to be, but I don't see them materially changing from from the small practice to a larger practice or as to employees of a hospital.
Well, personally, my malpractice went from $40,000 a year in 1994 to $110 in
Wow.
2010.
Mm-hmm.
We paid that, and at one time we had 7 orthopedic surgeons, 7 times whatever. That was a big nut. You know, human resources obviously is the single most expensive item in our line items, but right below that was malpractice, and it really became a burden to pay the malpractice. So much so that we shifted from doing it in quarterly payments to shifting into monthly payments. It was really a cash flow burden for us. Going to the hospital assumes that cost. We don't see that cost at all. And many of the hospitals are self-insured in regards to malpractice. So that may affect the rate. But my personal experience, my hospital now is paying my malpractice premium for the policy that I had. Now, I would imagine at some point in time, that's going to be subsumed by their larger malpractice, their own malpractice.
Okay. Anybody else on that?
Well, just to keep in mind that when these physicians, such as Dr. McIntyre, join a hospital-based practice, the hospital loses money. There's not a huge savings that occurs from him coming over. They typically lose money on these practices, but the hospital has to have physicians in the community, so they really have no choice but to bear that potential loss.
Okay. But I'm assuming, is it cheaper if a larger entity can be self-insured and manage its own liability, or do these hospitals still carry third-party insurance?
Well, Hospital Corporation of America in the metropolitan area of Kansas City employs over 250 physicians. I would think that they get a bit of an economy of scale to some degree if they stick with one insurer, and probably get a rate break to some degree. In looking at the new health care law, the Affordable Care Act, that there is a movement, I think, born of that to accountable care organizations. So there's been a trend prior, certainly, to the Health Care Act, a movement away, as you all have described, from the solo practice, the small physicians group, to larger practices and to employees at hospitals. How has the current health care law, or has it, accelerated that process?
There's no question it has accelerated that process. We had the fear of the unknown, and I think you've had a lot of wait and see to see what would happen from the Supreme Court's decision, and that it has picked up pace quite a bit. I would look at the fact to say you've got a combination of as ACOs come closer, hospitals realize there's bundled payments, they're looking for partners. At the same time, you've seen insurance companies not wanting to be left out. So you've seen with Highmark in Pennsylvania buying hospital systems. So there's a bit of a race for that finish line, and physicians, in my experience, running for cover because of the intensity of the penalties within the system. Some information we could provide, but there's so much more regulation, and the penalties are so great that I find physicians very, very fearful that they'll make an honest mistake and being held accountable financially.
speaking from my administrative side, I would say that probably the health care law has accelerated more on the part of the hospitals, probably more so than physicians, because of the fact of the accountable care organizations and bundle payments and measures in there that the hospitals want to be sure they have enough primary care physicians particularly, as well as specialists that they can, have in their accountable care organizations to be able to participate. I think it has brought about some acceleration on the part of physicians just because of uncertainty. But as we mentioned, as you mentioned, so many of these things we talked about actually predated the Affordable Care Act.
Sure. I'm going to ask one more question and then defer to Dr. Schrader, but then I'll come back. I'll come back probably, and we'll go back and forth. Oh, and I'm sorry, Ms. Hahn as well from California. And that is, you talked about the patient-doctor relationship being compromised, if you will, through the movement of the solo or small group practice to the larger group practice or to employees of a hospital. I wonder if you could all elaborate on that, and please be specific in terms of examples of how you think that it changes the patient-doctor relationship, this movement.
I think that one of the ways it changes that, when you become an employed physician, or particularly those physicians that come directly out of residency and become employed physicians and have never practiced in solo practice or own their own business, that it's more of a business now, and it's, I work for X number of dollars and I work X number of hours a week, and that's all I do. I may not stay a little longer to say, Mrs. Jones, let's work her in, or see that extra patient because they want to be seen, they need to be seen that day, and do that. And you hear stories about that all the time, about how physicians tend to cut it off and say, well, I used to see 30 a day, well, now I see 26 a day, or I see 22 a day, and those types of things. And it's a problem, I think.
My practice is 2 miles from my house, and so I take care of the people that live in my community. My reputation is predicated upon how I do that. So not only was I'm very concerned about being a good physician, but running a good small business in my community. And what I said before in the testimony was that I had great ability to affect the atmosphere and the business that was there because I ran it. So if things were brought to my attention by patients or staff or whatever, that we were deficient in this area or that area, well, you can be sure that we change that. Now, I'm really not responsible for the policies of the practice. The hospital is. So I'm a little bit hamstrung in my ability to affect those policies. Yesterday, a patient came in. Supposedly, one of our doctors wasn't on the insurance panel because the hospital hadn't ramped up the insurance verification yet. The patient was told, well, you can't see your doctor that you've seen for 10 years. And I was like, no, that's not right. The patient's going to see the physician. But if you never had that experience, perhaps you'd just say, well, whatever. So I think that when you're vested in your practice as a physician and also as a businessman or woman, that lends a whole different color to the way you approach it.
I might differ slightly because of the fact that I don't think being employed has changed my physician-patient relationship. I think I feel the same about my patients as I always have the past 30 years. There's a lot of regulatory and reimbursement issues that have affected relationships because we can't provide the services we used to provide. That is a real concern. And quite honestly, there is an evolution in medicine that's going to change physician-patient relationships. In fact, the fact that we now have intensivists, we have hospitalists, we have nocturnists, so we have shift medicine. And that is what the younger physicians like in many instances. And so that is changing the physician-patient relationship.
And I would add quickly, the difference to me for the patient is access. Today we have a shortage of physicians in many parts of the country, and the surveys I've read have shown that employed physicians, there's risk off the table, they're no longer business owners, see about 7% fewer patients. And this is at a time we already have a shortage, and we're looking to add 30 million people to this process. To me, that's a great concern.
Dr. Schrader?
Thank you, Mr. Chairman. Well, I thank the panel. As a, I guess, retired small business veterinary practitioner for 35 years, started my own business from scratch when you could do that sort of thing. My humble opinion, much as has been stated here, I mean, that's almost impossible to do. I don't care what sort of medical practice you're into. I mean, the tax laws have gotten Byzantine. I actually did my own tax returns when I started my practice. That was actually doable, and I felt like I wasn't committing, suicide. And the regulatory burden, and certainly those in the medical profession, with all the different regulatory frameworks come out, the SGR has been a sort of Damocles hanging over every physician's head. I don't care who you are. For many years, sometimes we treat it, and I get this way almost cavalierly here in D.C. because we, quote, never let it happen. But it's still there, and it's still disrespectful, I think, of the hard work that folks put in. Makes it pretty tough. The debt burden now that the youngsters came out with, I mean, gosh, my tuition, I'm embarrassed to say, veterinary college a few years ago, it's like $700. Students would kill themselves to do that. And I'm a dinosaur, but not that much of a dinosaur. But the other thing I think the panel's alluded to a little bit that didn't get brought out is, there's a change in attitude among young people. I don't care, and this is not just the medical profession. I see this in a lot of my other business friends and associates where the idea of starting a risk-based enterprise, while there's lots of great entrepreneurs in our great country, thank goodness, and that's what's going to make and continue to make, I think, our country great. In some professions, they're a little more risk-adverse for a lot of the reasons you all have just enunciated here. It seems almost daunting for these people with the debt they come out with, the regulatory burden that's out there, the uncertainty, and I will grant that the ACA does create some uncertainty out there. It's one of many issues I think face our medical community. I'd like to get to some thoughts about potential solutions going forward here. So I guess the one main question I'd ask the panel here is, of the many things you've talked about today, from taxes to debt to SGR to other regulatory burdens, ICD-10 codes, some of the aspects of the ACA. What is the single most or one or top two burdens that we should talk about trying to eliminate or change and make less burdensome for you guys to get back to, the practice of medicine that you all do so well? Dr. Kennett, work down the line.
So, Congressman, I think that, to me, without a doubt, the biggest thing you could do is to eliminate the SGR and have a stable platform for physician payment that's fair for the appropriate service that they're providing going forward, so the physicians on a yearly, monthly, sometimes basis don't know what the payment's going to be next year, don't know if their claims are going to be held, and they have to go borrow money to make payroll. So taking care of the Medicare physician, payment platform going forward would be a huge step forward.
All right. Mr. Yasso?
Debt.
Dr. Yasso, excuse me.
Debt, I think, is a very big issue for these kids coming out of school today or residency. If we could find a way to either help them defer their debt for a while so they have the opportunity to go into private practice, or if we could find a way, particularly if they go into underserved areas and take care of people that truly need help, to eliminate their debt so that they can stay in practice and stay in areas where people truly need their service.
Very good. Thank you. Dr. McIntyre?
I think as a philosophy, we might want to inject some market values into the relationship, the physician-patient relationship, and have providers compete not only on quality issues but also on price issues, which we haven't done in decades. I think that might go a long way to decreasing costs and increasing quality. If we decide we don't want to do that, then I think that to strengthen private practice, we need to allow private practitioners to band together to negotiate rates without onerous overhead structures so that they can compete with what's becoming a monopsony. We have the big medicine, big insurance, and the government. And with consolidation, I don't think we're going to get the cost containment we need. I think we need more players in the market to do that, and facilitating private practice negotiating position, I think, might go a long way to do that. Secondly, I think malpractice tort reform will go a long way to decreasing the costs not only of private practice but of medicine in general. And lastly, especially with the SGR being such a a problem and being so expensive, and the problems in trying to eliminate it, as well as deal with the Medicare reimbursement cuts that are supposed to go through with the ACA, perhaps we might want to think about bringing back balanced billing to the Medicare equation, as was part of the program for the first 20 years of its existence. I think it could be done in a way that wouldn't hurt seniors, but would allow private practice to maintain their access for Medicare.
Thank you. Mr. Smith.
Well, I agree with all three topics mentioned between SGR, medical debt, something we hear on a daily basis from the folks that we're talking to, and tort reform. I would add to tort reform that the impact goes beyond the premiums and malpractice. The cost of defensive medicine has been something that's been calculated into incredible numbers, where physicians are forced, they feel, to protect themselves by doing additional tests in a normal circumstance they might not do. So that cost is significant. The other thing I would mention is to relax some of the regulations in Start 2, as it applies to recruiting a physician to a community. Being a solo practitioner is near impossible. If you can get a partner or two partners, you have a chance. Unfortunately, the stipulations, probably unintended in Start 2, make it difficult because you cannot share any of your costs. You have to bear the burden of the costs that existed to bring a new associate in, and most physicians can't go through that year process to wait for that new person to contribute to their overhead to be able to afford to bring them in. So that would be a real benefit.
Very good, very good. Dr. Yasso, you talked about medical home maybe being, and I've thought about this myself, as maybe being a way to get back to where the physician is ultimately in control. One of the things that is in the ACA that maybe needs to be fleshed out more, there was some loan forgiveness over a period of time, at least for new students, and then we tried to give a little better deal for primary care docs that actually opted to go into some sort of, DOs in particular will do that, but into primary care. But I thought maybe the medical home, and everyone's alluded to this, I mean, the doctors have to be in charge of the decision-making, not the hospital, not the insurance company, not, the outfit you hire to run all your books and stuff. And can you elaborate a little bit about what we should be looking for, how we should be talking to CMS about how to organize this so the docs are in control?
Well, I think the PCMH is set up in such a fashion that it is under the control of the physician. It's a collaborative approach to medicine where it's a team approach where everybody's involved in the care of the patient. That includes the medical assistants in your office, your nursing staff, even the front office staff for that matter. Everybody's involved in the care of that patient rather than, and you're on an even footing to a degree, and things are done for the patient by everyone, not just the physician, not just the nurse, but everybody gets involved in the care. That's the whole idea behind the patient-centered medical home. And then you develop relationships as a primary care physician. You develop a relationship with specialists that are going to provide quality care for your patients, and you deal with those people and you discuss the care so that you know what kind of care that individual is receiving is the best possible care that they can get. If you take that a step further and you look at the accountable care organizations, I was talking to a physician yesterday who practices in the Phoenix area, and they've been very successful in setting up an ACO down there that's driven by primary care. It's not driven by the hospital, it's not driven by the specialist, it's driven by primary care, which seems to be very cost effective and providing good quality care. So I think two things we need to keep in mind when we talk about ACOs in particular is they need to be driven by physicians, not the hospital. My concern when I first started hearing about ACOs was that they were something akin to the old PHOs, physician hospital organizations, which for all intents and purposes was driven by the hospitals. And that's what we really need to avoid, because the care, the rubber that meets the road is where the patient sees the doctor, and that's where the care is delivered. It's not by the hospital, per se, on a daily basis. So the physicians really need to be in control of that.
Dr. Kennett?
I just would like to make just two additional comments about medical homes. The first is, medical homes, as Dr. Yasso said, require some additional resources within your office. People teaching dietitians, and so we have to make sure that they're reimbursed adequately, that they're going to be able to provide those additional resources. And the second is that the medical home needs to be assigned to whoever actually should be in control of that patient's care on a regular basis. If that's a patient that's on dialysis, then really their nephrologist probably ought to be their medical home. If it's a patient that's got chronic congestive heart failure, then probably the cardiologist. There's a huge majority that should be in the hands of the primary care physicians, but it needs to encompass all these other specialties as well.
Just a final comment then, Mr. Chair. I really appreciate this panel, and the topic we're discussing is near and dear to my heart, and very concerned about the future of medicine from all walks of life. As a little old country veterinarian, I enjoy the opportunity to get to know my patients, see them from birth to their passing, and that's a beautiful thing. But I rely on the specialists, and I think we've got a great relationship in veterinary world where we're not afraid to send it out. In the old days used to be you kept everything pretty close, but medicine has changed. Hopefully physicians, veterinarians, and other practitioners of all sorts have come to that realization, and we'll work through that. I guess my last point would be that I hope each and every one of you are active in making sure that whatever comes out of healthcare evolution, whether it's related to ACA or anything else, that we work hard on it. Some of us are pushing to reform the SGR. There's a bill out there I'm co-sponsoring with Allison Schwartz and others to get rid of the SGR and get to a smarter level playing field, so you guys feel like you're part of the solution and not just part of the whipping child that's out there at the end of the day. But hopefully it'll be a good process, a better process at least, going forward, and I appreciate the Chair bringing this issue to Small Business Committee's attention. Thank you, sir.
Thank you, Dr. Schrader. Ms. Hum from California, and I'll relax the 5-minute rule.
Thank you, Chairman Kaufman, Ranking Member Dr. Schrader. I really want to thank the Chairman for holding this hearing. Really appreciate the witnesses that are here today, all of you who are involved in some aspect of health care and getting folks healthy. We really do appreciate what you're doing. It's interesting because, I know the more the Affordable Care Act is implemented and is fleshed out, I think a lot of the issues, as I understand it, that you've brought up today are actually addressed in this new law. Loan repayments, there's a lot about helping students repay their loans or forgive their loans, particularly if they serve in areas that have seen a shortage. You talked about, Mr. Smith, the shortage of physicians. There's actually a lot in this Health Care Act about providing incentives and scholarships to encourage more doctors, physician's assistants, folks to go into this field. I agree with Dr. Schrader. There's many of us who want to have a permanent doc fix, and I hope we do that in Congress with the SGR. This is a small business committee, so it's really interesting to hear your views as it relates to being a small business person. I'm wondering, how much training did you get? How much are students in medical school actually getting business training? Should we be partnering with business schools and medical schools? And again, I'm always trying to figure out what our Small Business Administration is doing to help small businesses. Is there a better role? Is there any role? What's our Small Business Administration doing as it particularly relates to physicians who are attempting to run a small business? And what can we do better to, help that aspect so that it sounds like we'd like to ultimately see more doctors continue to be in the role of being a small business owner?
Training would be zero.
Okay, good to know.
On-the-job training would be a birth of fire. We learned it on the fly, many of my colleagues who I interact with in the regulatory arena have gone on to get MBAs. I know a boatload of orthopedic surgeons MBAs. So there are a number of people who are doing that. But in terms of the Joe Lunch Bucket doctor, I think that training is pretty much zero.
So in medical school, there's no sense that it could be an important part of your your success as a doctor who wants to be also a small businessman?
Some of the schools, my alma mater being one, offers an MBA degree, but not to everybody. They keep it to a very small number of students that can get involved in that. So there is some, but as far as any kind of formal training for everybody else, or even just some basic business courses, no, there really isn't. You know, as far as what can you all do? You know, promote some of the things we talked about, I guess, you know, and some of the things that you mentioned that are in the Affordable Care Act that might be helpful to make sure that those things come to fruition. You know, if they're unfunded mandates, they don't do us any good. So that's really the key to see that some of those things come out and really give us what we need to promote people to at least consider going into solo practice or small practices.
Congresswoman, I'd say that certainty going forward is what these small businesses need, and that relates to what we said: reimbursement, knowing what you're going to get paid down the road, and reducing the regulatory burden, which is huge. If you could help those two, you'd have a lot more physicians staying in practice.
You know, I want to follow up on that because the Affordable Care Law also aims to reduce paperwork and administrative costs by standardizing billing. And between 2013 and 2016, the rules will be implemented to standardize health insurance processing requirements. Mr. Smith, you worked on this Merritt-Hawkins white paper where quote is, physician practices should benefit from improved revenue cycles and save time and money tracking claims. So I'm thinking, since these rules are not finalized yet, maybe this is an opportunity. You know, your white paper suggests that this is a potential cost saving. So while we're considering these rules, what should we be keeping in mind to maximize these potential cost savings within this particular realm?
Well, anything we can do to keep it as simple as possible would be a plus, which obviously we saw the depth and the weight of the Affordable Care Act just in paper alone, and people are just really digesting all the areas and attempting to define some of those areas, and you know, to lessen the penalties in certain areas where things are unknown. There is an example as which, if there is a whistleblower situation, the Medicare can suspend payment to the physician before that whistleblower act is verified. So in essence, you could have a disgruntled employee who makes a claim, Medicare suspends payment to the physician, and it's over. And I would bet the three physicians on this panel, if you had zero Medicare revenue from guilty to proven innocent, could crush any of their practices. There's several examples like that. Again, unintended consequences.
Thank you very much.
I think that to standardize the billing process, as you allude to in the ACA, would go a long way. For example, Medicare was about 23% of our business, but was our most prompt payer. We could anticipate Medicare reimbursement within 18 days of the bill being sent out, as long as it was a clean claim. Managed care companies, on the other hand, our time frame was 45 days. And we got much more runaround and hassle from the managed care companies in regards to them saying a claim wasn't clean, them wanting more information. So a standardization of that process, I think, would go a long way to help private practice.
Thank you.
Congressman, can I give you one quick example of one of the regulatory things that happen to physicians that make no sense? So the RAC auditors, that I'm sure you're probably familiar with, that can go in and take money back from hospitals for whether the patient was inpatient or outpatient. So now, you know, a patient can be in the hospital, and just because of some regulations of will you qualify, you tell them that they're inpatient, or you call them an inpatient or outpatient, same exact services provided in the hospital. But then the RAC auditor comes in and says, no, they should have been called an outpatient. They can take back the physician's reimbursement, any services that are provided during that hospitalization. Really makes no sense.
Thank you.
So there's one additional program too, the Medicare administrative contractors, which is also retroactively denying services for lack of paperwork, or for example in orthopedics, where if you haven't failed at least 3 months of physical therapy before you have your total joint replacement, which then there's nothing in the literature that supports that. And the rules of these programs are unknown, and they're enacted retroactively, and it really will affect patient care negatively.
Thank you.
Thank you, Ms. Hahn. Chair recognizes Mr. Tipton of Colorado.
Thank you, Mr. Chairman. I apologize for being late. We had a natural resources meeting as well, so I sent your regards to that meeting. I know you couldn't be there because of here. I'd like to thank our panel for being here. Incredibly important issue, particularly for districts like mine, rural Colorado, 54,000 square miles. And as I've traveled through those 54,000 square miles, just held a town hall meeting with senior citizens in Pueblo, Colorado last week. They're worried about the President's health care mandate and how it's going to be able to impact them. I've talked to senior citizens in Del Norte, Monte Vista, Alamosa, Cortez, Crawford, Hotchkiss, Egner, some towns a lot of people haven't even heard of. They can't find a doctor that is willing to take Medicare. So I guess, Mr. Smith, I'd like to be able to start with you. With the number of small businesses, and a lot of our doctors are small business people, solo practices, what effects will the President's health care mandate have on rural Americans, rural citizens' access to health care from your perception?
From my perception, the impact I look at first is of the patient. As you mentioned, it's very difficult as a patient, a new patient to physician practice, to be seen if you have Medicare, especially if you have Medicare without any kind of gap insurance. A physician has to limit the amount of Medicare that they see in their practice to be financially viable. If you have a pure Medicare practice, it's not viable. The reimbursements are too low to be able to do that. Most physicians that I work with, we conduct about 3,000 searches a year across the country, so we have an excellent resource of information, will tell me that Medicare rates generally put them at a break-even. That's their cost of doing business. So you've got to keep that to a third of your practice. And some specialties, such as internal medicine, you might get it to half, but you cannot have that happen. You see physicians, as they get older, their patients get older, they have more and more Medicare, and you can look at their financials, and they slowly dwindle until such a day that the decision is, I'm working for free, I've got to get out of practice. So now as we look at this, we have patients that could come under the system at was going to be a Medicaid rate, and we're elevating them to Medicare, thinking that's going to be a driver for physicians to see them. One, that's a temporary raise. Two, it's not attractive. And those physicians, those patients, the 30 million people we're adding to the system, will have a card that gives them insurance or a version thereof. What they will not have is access. The second piece of that is supply and demand. The legislation does address some areas of need of attracting people to the system. There's a shifting of unfilled primary care spots that really is resulting in a few hundred physicians. But the issue is we can add as many people as we want to the medical schools, but we haven't added a single dollar as it comes to the residency program. And so all you'll be doing is shifting foreign physicians out of the system and replacing them with American-trained physicians. But at the end of the day, it's the same number of physicians coming out of the machine. And the places like Brush and Trinidad and Sterling will still not be able to find a doctor because there'll be more attractive options in the larger cities.
Good. If we could, Mr. Smith, I'd like to explore that a little bit because you were focusing a little bit on the economic end of it from the doctor's perspective that's sitting there. Majority of doctors I know actually went into healthcare because they truly care about people. They're going to limit the number of patients that they can see simply because they want to be able to provide quality health care. If you're trying to run them through like an assembly line, is that going to reduce the quality of health care?
Well, there's no doubt. I mean, the physician-patient relationship is the most critical thing that we can talk about, and our three colleagues here, I'm sure, would completely agree with that. But your only choice is to do more. And I would bet that each of these physicians here see a few more patients each year to be able to make their practice viable. Not so much as to just financial reward, but just to make it a viable business. They have employees, people to count on, and your own income is it. But the patient will be left on the sideline.
And yet you just mentioned doctor-patient relationship, that we shouldn't be getting between that if there's going to be a medical decision that is to be made, let's have the family, the patient, the doctor do that in the doctor's office. Do you have some concern about the IPAB board?
Well, yes, to answer your question. We've seen this in other countries, and we've seen some of the impact that it's had. I saw recently in Europe where epidural injections were taken off the list of care that will be provided, other decisions that are being made. But each of these decisions that you've seen along the way, the majority of these decisions are made without physicians involved. We speak to thousands of physicians on a monthly basis, and I've yet to find any of the ones that had the lab coat and were on the front lawn during these conversations. But anything we can do, it has to come down to this physician-patient relationship.
Dr. Yassett, saw your head nodding. Would you like to make a comment on that?
I would agree, and the American Osteopathic Association adamantly opposes the IPAB. We think that's just wrong-headed, if for no other way to say it. You know, the other thing that is concerning to me in regards to Medicare, as Mr. Smith said, you know, you're almost getting to a point where you're just barely breaking even as far as reimbursement is concerned. Mm-hmm. What happens in the next 10 years when they cut $500 billion out of Medicare because of ACA? Does anybody know? I mean, obviously reimbursement's going to take a hit. It has to take a hit. I don't see how else you're going to reach that number.
Excellent point. Dr. McIntyre, maybe you'd like to jump in a little bit on this, because I think Mr. Smith said it just very well. We can insure everyone in the country, but there is a quantitative difference between insurance and health care, two completely different things. And if we're wanting to be able to get health care, are you seeing a real problem with the President's health care mandate when it gets down to actual delivery of health care? And I'm speaking primarily for rural America, rural Colorado. I know some of our metropolitan areas have an abundance of doctors and specialties, but let's talk about rural America.
I don't know that the mandate in itself creates an access issue. I think the access issue is really driven more by reimbursement levels. So if your reimbursement level falls below the level of your ability to deliver the care.
But the reimbursement level is actually via the mandate. That's part of the program.
Well,
right?
my understanding of the ACA is that it does cut $500 billion out of Medicare.
$575 billion.
Over 10 years, and does fail to correct the SGR, which is another $300 billion. So I think that's the access issue there. I think I certainly have an issue, a philosophical, constitutional issue with the mandate for myself personally. But perhaps I'm not sophisticated enough to realize how it will impact access, other than the issues we spoke to of, well, it is possible to provide someone with insurance, but if that insurance doesn't pay costs, then you're basically uninsured. For example, if you put people on Medicaid, I think it's something like 40% of all physicians won't accept a Medicaid patient because the reimbursement is so low. And I believe my understanding of the ACA is that by 2019, Medicare rates will be around where Medicaid reimbursement rates are now. So I think that is a huge issue and a potentially devastating one for access to care for Medicare patients going forward.
So effectively, our senior citizens, people who have run the race, are walking in the door with their Medicaid card, putting it on the table, it's insurance, and they aren't able to get a doctor.
I think you could definitely see that problem.
That is a real challenge. Mr. Smith?
I would add to it, one of the things that my firm does is we do studies on wait times. How long does it take to get to see a physician? And an unintended outcome that we discovered was the greatest increase in wait times of any metropolitan market was Boston. And the difference between what occurred between our first wait time survey and our second was the implementation of universal health care. So a place that I think any of our colleagues would argue have the most physicians, the most training programs, the environment you would not expect to have that issue are having that issue. So if that's happening in Boston, what's going to happen with your rural constituents? I don't think that's a difficult question to ask.
Right. Dr. McIntyre, maybe, or any of you if you'd like to, we've got to be able to address some of the accessibility. Every American, I think that we can all agree, we want affordability and accessibility. The President's health care mandate fails on both counts. What can we do? What should be done to be able to increase the number of physicians that are going to be able to get into some of these rural areas, to be able to provide that access to health care?
In answering a similar question before, I thought perhaps injecting a market solution to this problem would go a long way to improving quality, decreasing costs, and improving access. I think if patients have some skin in the game, then they are more likely to seek health care that is of quality to them. If somebody else is paying for their health care, especially if it's first dollar coverage, they're less likely to become shoppers. They're less likely to search for quality. they are much more likely to search for volume. So I think in the current situation, we have a volume-driven process that's going to be exacerbated by the health care law instead of one where we'll be looking for quality. The health care law does attempt to impose quality on the system through comparative effectiveness research and other things, but that's it's sort of a top-down approach.
You know, ultimately, and I'd just kind of like to get your thoughts on this, original CBO estimates on the President's health care mandate stated that it was going to cost $900 billion. And in the White House, there was dancing in the hallways over that number. I'm a small business guy. $900 billion is a lot of money. CBO just rescored this. It's going to be $1,787 billion with administrative costs. We're going over $2 trillion. Is there a better way to be able to spend $2 trillion?
Congressman, I'd like to just comment a little bit on before and then this question as well, and that is that if we're going to increase access, we have to be able to pay for it. And so that's a concern. We have to appropriately pay physicians for the services they perform. So if we're going to reduce costs within the system, I think if you get any large number of physicians in a room and talk about how we're going to reduce cost, that you will come to the issue of utilization. And so the American College of Cardiology for years has been working on appropriate use criteria and our registries. And I think that we, as a profession, are going to have to look at appropriate utilization and cut out the utilization that's inappropriate, and that could save, you know, possibly as much as a third of what we're spending right now on health care.
Mm-hmm. Would tort reform be a good idea?
Absolutely, and I was going to just mention that. You know, the patient comes in with back pain, let's say, and you know, you may send them and get X-rays of their back. Let's say low back pain. They come back and they say, "Well, doc, you know, you gave me some medicine. It really didn't help. I still got the back pain." You know, and the next thing you know, you're ordering an MRI. Mm-hmm. And why do you do that? Is it because it's really a necessary test? Or is it because you're worried about the liability of the situation? If you know, am I missing something? You know, or is there something else going on here that I'll pick up with the MRI? And you're thinking about the legality of the situation more than you are. Is this really appropriate care for the patient? And I think that's, you know, medical liability is what's perceived a lot of times, and I think that's really true in the ER setting. And you wonder how much money spent needlessly in the emergency room on CTs of the head, stress tests for chest pain, you know, all those kinds of things where they may not necessarily be needed.
Well, you may have been a little like me. Thought it was curious that the administration and the 111th Congress, we're in the 112th, wouldn't even consider tort reform, because I've actually held meetings with physicians. Just met with about 24 physicians over in Glenwood, Colorado. Tort reform came up as one of the #1 cost drivers, and it's the fear factor that if a patient isn't totally forthcoming and you didn't catch it, you can be sued. We've got to be able to bring some common sense into that portion of the equation as well. So certainly thank our panel for taking the time to be able to be here. I am, and we'd love to be able to hear more from you. This is about affordability. It is about accessibility. And as I travel through rural Colorado in my district, I'm talking to senior citizens right now who are frightened about what the consequences are going to be to their health care going forward as we continue to see the President's health care mandate put into place. And I think maybe we should have started with you at the very beginning. Talk to the physicians before they started writing a 2,000-plus page bill that many of them didn't read yet passed. And Minority Leader Pelosi was correct. She said, we'll find out what's in it once it's passed. Unfortunately, that discovery is still continuing. We're seeing increased cost, increased control, and reduced access to health care in this country. Thank you for coming in today. I yield back, Mr. Chairman.
Thank you, Mr. Tipton. I've got a few other questions. I want to make sure that we have everything down on record. Dr. Giaimo and Dr. Kennett, in your written testimony, you both mentioned the burden of complying with statutory and regulatory requirements, particularly electronic health records. electronic prescribing and physician quality reporting, which will carry significant penalties for noncompliance in future years. Would you elaborate on how these burdens disproportionately impact a small or solo practice physician's time and revenue?
I have a good friend that practices in Kansas City and has a predominantly Medicaid practice. She has chosen to date not to implement an electronic health record because of the expense. I mean, she's barely breaking even paying her help, you know, taking a salary and those types of things. And she's a very altruistic person, and she wants to take care of her patient population. But she can't afford, and even, you know, even though the government says, well, we'll reimburse you if you put in a system that is compatible, or I forget what the terminology is for that. But anyway, she's made the decision that in 2014 she's going to retire, and the community is going to lose one darn good doctor because of that. And it's those types of things. It's just a heavy burden in situations like that, and it takes good people out of the practice of medicine.
Thank you.
So our group of physicians, we were only 11 at the time, we spent about $700,000 on electronic health record. And, you know, you don't recoup very much on an ongoing basis. You have that expense of maintaining it on a regular basis. And the other bad part of that is when you first institute an electronic health record, it actually reduces your productivity pretty dramatically for the first 6 months or so, and then you come back, but you never really get back to where you were before. So you're going to have electronic health record to participate in meaningful use, and if you don't, you'll get penalized for you know, all your Medicare funds will be cut by a certain percentage because you're not participating in meaningful use, and you're not e-prescribing, and you know, it goes on and on. So that's one of the drivers to hospitals, is because the hospital can better afford, you know, they still have the similar costs involved, except they can better afford to absorb those costs than the small physician practices.
Okay. Mr. Smith, your testimony mentions the high cost of malpractice insurance. Do you think malpractice reform would help small practice physicians to shoulder this burden, and how so?
Well, I think if tort reform would have been part of the legislation, you would have seen a much greater acceptance of the physicians of this of legislation and the changes that were coming. But we have seen in states that have applied tort reform that it's a significant cost savings to the physicians. And then, of course, what I mentioned before, the cost of defensive medicine, which is an intangible cost that is significant, would be impacted as well.
Mr. McIntyre, Dr. McIntyre, some healthcare mandates, such as the reporting requirements for health information technology and establishing accountable care organizations, are first instituted with quote-unquote incentive payments, but involve penalties later. Do you think that the inability to comply with mandates may be contributing to the disappearance of small medical practices?
The short answer is yes. We implemented an electronic medical record in 2002, so we were early adopters. Totally, we spent $500,000, which was about $100,000 per doctor. We initially saw some savings because we were able to get rid of file clerks and paper costs and transcription costs. But going forward with upgrades and having to hire new staff to enter data, those cost savings went away. So basically, it's a huge cost for a small business. The HITECH Act leaves physicians $44,000 over 5 years to implement a record as long as they comply with meaningful use. So that wouldn't even cover half of our investment per doctor. In addition, the quality reporting in much of the Act is very difficult to comply with because of the quality reporting criteria have been developed by the National Quality Forum and places like that. Of the, I think it's 44 quality measures, only 3 of them apply to orthopedics at all. So we were trying to fish around for we're going to start asking people about smoking and asking people about, looking at things that had, sometimes had nothing to do with what they were seeing us for. We have to report those things, even though they're not in the scope of our practice, just because of the reporting regulations.
Okay. Dr. Kennett.
Chairman Coffman, I'll just give you a quick personal anecdote about tort reforms. Missouri has a tort reform law with a cap on non-economic damages of $350,000. So my insurance as a interventional cardiologist dropped from $35,000 to $14,000.
Wow. Thank you. Okay, Mr. Tipton.
Thank you, Mr. Chairman. I just did have one follow-up question. Dr. McIntyre, you had brought it to mind, and it's not in regards to the electronic medical records, but going back to Medicare, being able to fill out the compliance forms to be able to get paid. Has it been your experience, maybe in all of your professions, I've talked good family practice doc in my hometown, finally just pretty much quit simply out of frustration from the standpoint that they had moving bars when it came to being able to fill out the forms, make sure they filled in the right dots, and it was constantly changing. Have you run any analysis in terms of the cost, how much you were spending rather than spending time with patients? You're paying people to be filling out more records when it comes to Medicare?
Well, certainly our costs in general increased significantly to the point where they were about 80% of revenue for our clinical practice. We had other portions of the practice that evened that out to a total overhead cost of about 63%, but that had increased hugely since the earlier part of the 1990s. We've never culled out Medicare specifically to analyze the cost just for Medicare patients, but overall it increased tremendously. We employed, when I started we had one billing person. When I left we had 6. When I started we had one person to do pre-certifications and things like that. When we sold the practice we had one person per physician. So all these things added up over time.
I'm sorry, I apologize for interrupting, but just so that I'm clear on that, it didn't mean that you were seeing more patients, that you were putting out more bills. It was just compliance costs.
Right, just compliance, correct.
Just strictly compliance.
We did have to ramp up volume too because we couldn't
pay for it.
Since we were getting a set fee. There are 2 ways for a private practice to increase income in a set fee market, and that's to see more volume or to add ancillary services. You can decrease costs, but quality, the quality of your service suffers to the point where you're not worth going to see.
Dr. Kennett?
Congressman, I would just say that I hope CMS isn't listening, or the Department of Justice, but if we, if on a regular basis a physician actually read all the documents that you're supposed to sign every day, it would add hours to your day. There's no way. You have, reams of documents that you go through every day and you sign your signature on, whether it's home health or, hospice or Medicare, documentation. It's huge, and there's just no way you can actually even read it all.
When I first started in private practice in 1980, there were 3 of us, 3 physicians, and we had 4 people working for us, 2 in the front office, 2 in the back. That was it, and we did just fine. Today, with 4 providers, 3 physicians, 1 nurse practitioner, we have an office manager, 4 people working in the front office, and 4 people working in the back office. So, I mean, realizing we've got 1 more provider than we did 30 years ago, but still, all this regulation and all the things that we need to do, the pre-certification of everything, you just have to have more bodies. You can't get by without them.
Just to give you it's no consolation, but in this country, businesses are paying $1,750 billion per year on just regulatory compliance. Small businesses are paying $10,685 per employee in regulatory compliance. And we all know there needs to be some regulations, but I think we've certainly seen an overreach and a complexity that is inhibiting the very important work that I know you physicians in particular want to do, and that's to be able to provide quality health care at an affordable price. So thank you. Thank you, Mr. Chairman. Yield back.
Thank you. Dr. Giaimo, I've got a question. Do you think smaller solo practices may survive, but only if they fill a particular niche, such as concierge care?
I think that's could be the way that this goes. I have a friend of mine that has started a concierge practice, at least part of what he does. He doesn't do 100% of that yet, although he may very well move into that direction at some point in time. It's my understanding that you see a lot of that, and Mr. Smith could speak to that, I'm sure, on the East and the West Coast, and I'm sure that eventually that's going to move towards us. It only makes sense from the private practitioner, if he wants to stay private, that he does something like that, because now he controls his income. It's not controlled by the government. It's not controlled by any regulator. He controls his income, and it makes sense.
Okay. I'd like to address specifically with that, the concept of concierge medicine. People think of it as the billionaire that has a doctor that follows him around, and that does exist. But if you are a private practitioner, a primary care provider in solo practice, you're going to have 3 to 4 employees. You're going to have 50 to 70% overhead costs, and you're questioning, what are you doing? Do I join a hospital? If you could today become a concierge physician, you can take that panel, which could be as low as 2,500 to maybe 4,000 patients, and if you had 500 of them agree to pay you $50 a month, you would see them just in their office and take care of all their needs, you would make about 20% more money than you made the other way. So you can survive, but from the small business perspective, you would trim your staff to 1 or 2 people. So very lean. And those are good paying jobs that we hear talk about, have health insurance, a big part of the community. But these are smart individuals. They'll find a way to adapt, and coming off the grid and doing that is one way. And the second thing I would keep in mind is, what if you're not one of the 2,500 that can afford the $50 a month? So we've taken that FTE from a full physician down to about 15 to 20% of an FTE in an environment where you already have a demand challenge, or supply challenge, rather.
You know, my final question involves seniors, seniors on Medicare, seniors in my district and across the country. And seniors on basic Medicare have had a very challenging time, an increasingly difficult time in finding physicians that will see them. And with the Independent Payment Advisory Board that will be fully online, I think, in 2015, according to the Accountable Care Act, Affordable Care Act, isn't that going to make the situation all that much worse when the new way of controlling spending is to have this 15-member board control spending through restricting reimbursement levels to seniors, essentially. That's how we're controlling spending in the Medicare system. And so I wondered if any of you have any comments on how you see, where you see senior care going under Medicare.
In addition, I believe that the IPAB not only is tasked with cutting costs significantly, but also with maintaining access at the same time. So I don't know how they can do that. And I don't know how central planning is going to be able to affect a fair or reduction or a program, especially without any input from anyone. I believe there's no input from physicians. There's no input from the Congress. They basically just give Congress a report, and the Congress can accept it or not. Currently, at least now, we have some input to our reimbursement levels via certain committees of the AMA. That will go away with the IPAB.
Certainly, in the environment we're in, where there's uncertainty about Medicare reimbursement, seniors are going to have increasing difficulty getting access. You're exactly right. I think we all here would agree that the iPad is not a good thing, and it really is not a good thing, and that the only people that can really cut between now and 2019 are providers. And so the good news is, I think that in the current congressional environment, it seems very unlikely you're going to get 15 people approved by the Senate to be on the board, so it's not going to be implemented.
Well, and I would argue that they are regulating and controlling prices for services that in large don't occur because they can't get access.
Anyone, any further comments? Okay. Well, thank you all for participating today. I ask unanimous consent that the following articles be admitted to the hearing record. A New York Times article dated March 25th, 2012, entitled "More Doctors Giving Up Private Practices." A CNN Money article dated July 11th, 2012, entitled "Demise of the Solo Doctor." A Wall Street op-ed dated July 5th, 2012, entitled Obamacare's Lost Tribe Doctors. A Forbes article dated July 2nd, 2012, entitled So Long, Marcus Welby, Obamacare. Market Kill the Solo Private Practice. Without objection, so ordered. I ask unanimous consent that members have 5 legislative days to submit statements and supporting materials for the record. Without objection, so ordered. This hearing is now adjourned. Thank you very much for your testimony today.